Good morning, everyone. Glad you made it to the last day of ASA, or second to last day of ASA, and thank you for coming to our presentation this morning. Our presenters this morning, I'm Rebecca Gerlach. I'm an associate professor of anesthesia at the University of New Mexico, and my co-presenters need no introduction, but Dr. Bobby Jean Schweitzer and Dr. Adriana Opria will be my co-presenters. And our talk this morning, we're going to be focusing on coexisting diseases and anesthesia and all about timing issues. We do want to point out that this session will be part of the Center for Perioperative Medicine, so the CP Med program. This is something where you can actually purchase the 10 CP Med lectures that are comprising the content for this year from the ASA website, and it's an initiative from ASA to support perioperative medicine learning and education with the conference. And there's a QR code if you want to learn more. And the other thing for our talk today, we're going to be having a number of polls and questions that you can pull up on your phone. And basically, each of the cases will have some teaching points that we're going to ask you to answer, and the answers will be up on the screen. So if everyone wants to use the QR code to pull it up on their phone, and if you're not able to do it and you decide to do it midway through, there's going to be QR codes on each of the slides so you can pull that up as you go. I'll give everyone a second here just to get that, and then we'll get going. All right, yes. That's okay. Yeah, we're good. Thanks. Great, okay. So all of our talks, all of our teaching today is gonna be very case-based, and there's gonna be a few cases as we go. So our first case today is there's a patient that you're seeing in advance of surgery. Surgery is 7 days from now. She's a 57-year-old female having a total knee arthroplasty. She has a history of a CVA 4 months ago. She also is on hemodialysis, and that's been for the last 4 years via fistula, and she's very compliant with her Monday, Wednesday, Friday hemodialysis sessions. She has a history of rheumatoid arthritis, that's why she's having her knee replacement, and her medications include aspirin, since she had the stroke, lisinopril, methotrexate, and adalimumab, the Humira. I'll just say Humira because that's easier to say. So our first question for the session is, what do you think about timing? Are you going to go ahead in 7 days from now or not? This is our first poll. Let's hopefully see that it works. Okay, so did that work for most people on their phone? I hope so. Okay, so we have a bit of a mixture. The majority of people are saying no go, but and then 47% of people are saying go. So this really brings up the question of what do you do with someone who is having an elective non-neurologic surgery and they've had a recent stroke? And the most relevant paper related to this was published by Glance in 2022, and it looked at the association of time elapsed from surgery and the risk of recurrent stroke in older patients undergoing elective non-neurologic surgery. And you can see that within 30 days, you have an 8 times higher risk of having a recurrent stroke if you go ahead with surgery. If you wait in that 2 to 3 months, so 61 to 90 days, your risk is still 5 times greater, but it doesn't really decrease much more if you wait longer than 90 days. With the risk of all-cause mortality within 30 days, again, it's 2.5 times risk. It goes down when you are in that 61 to 90 day window, but still elevated over baseline. But the findings of this paper were really that if you wait longer than 90 days, you definitely should wait some time after recurrent surgery. So in a patient who had a stroke 4 months ago, is there a benefit to waiting longer than that 90-day period? Probably not. And so in this case, that patient, it would be reasonable to say, no, it's been 4 months, it's okay to go ahead with elective non-neurologic surgery. Okay, so the next part of this is, what do you advise? So we said that she was on methotrexate. What do you advise for her methotrexate? And there's actually 2 relevant guidelines for that will help us with managing this medication. It's an immune suppressant, so you want to be cautious with that with surgery. So the SPACI consensus statement and also the American College of Rheumatology and American Association of Hip and Knee Surgeons have both put out recommendations for what to do with some of these medications. So both the SPACI and the AAHKS guidance say that it's actually okay to continue methotrexate throughout surgery, and it's not going to adversely affect, it's probably beneficial to continue versus holding it without affecting the risk of infection. So So our next polling question, so this patient's last dose of Humira was 4 days ago, so it's an injection medication. What do you do about this? So in terms of this medication, what would you go ahead and proceed with surgery or hold? Okay, so again, a lot of people have said, nope, go ahead, it's okay with the Humira, and some people are saying, no, stop and don't go ahead. So again, let's go back to our 2 consensus papers or guidance papers. So the concern with biologicals or like Humira and a lot of the injection medications, if you forget which one's which, if it's an injectable, that is something that you get dosed every 2, 3, 4 weeks. Those are often the biological medications that have a much more significant effect on wound healing and on immune suppression, and are more of a concern for both the surgeons and also for us as far as ensuring patients have their best outcome. So in this case, both of our relevant societies do say that it's best not to proceed with surgery when patients have had a recent Humira dose. So in this case, because it's dosed every 2 weeks, the recommendation would be just to schedule surgery on week 3 so that you don't have to miss a dose. But definitely if someone has had it in the last week or so, it would be best not to proceed with surgery at that time. Okay, and then our last question is, again, we said this patient was on dialysis. So you're seeing the patient, the week before surgery, and she tells you surgery is next Monday at 10 a.m., and that means her last dialysis session is going to be on the Friday before surgery. Her dialysis center says, she says she can't get in on the weekend. Pretty much no dialysis center offers dialysis on a Sunday, so regardless, it's going to be at best, Saturday. But she says, well, I've been waiting for this surgery for 5 months. Are you telling me I can't have surgery next week? And this nice lady on the side there is really anxious about having surgery. And so what do you think? Are you going to actually say that you can't have surgery next Monday, or is it okay to go ahead? Perfect. So again, another mixture. So these are all, I guess, great topics of conversation because you can see there's a lot of variability in how people feel about how significant it is to go ahead when, our recommendation typically is to just have dialysis the day before surgery. But how important is it? And should we really be insisting on this in a clinic setting or even on the day of surgery? And so most of us in the room are thinking that we would not go ahead. But again, what's the evidence or what's the literature behind this? So there is an association between preoperative dialysis timing and postoperative mortality in patients with end-stage kidney disease. So if a surgeon sort of asks you, well, does it really make that much of a difference? I mean, if their potassium is fine, let's just go ahead. Their volume status is fine, let's just go ahead. There is a difference. And so this paper basically looked at the interval between the last day of dialysis, whether it was 1 day before surgery, 2 days before surgery, or 3 days before surgery. And it's actually pretty common when you think about it. Most patients that are on that Monday, Wednesday, Friday dialysis, if they have a Monday surgery, it's going to end up probably being 3 days from their last dialysis session. It's pretty common unless they're able to get in on the weekend, and then maybe it'll be at best 2 days. So this paper looked at a mortality difference between those intervals and whether it was a 90-day mortality risk. So, most of the time we think, well, what we do on the day of surgery is probably not making that much of an effect 90 days later, but this actually showed that there was a big difference between proceeding with surgery and not in those patients that had recent dialysis versus not. And if you look at the sort of incidence it's obvious even just by looking at it as far as the difference in trajectory. And you might say, well, why would that be? That one episode of care would actually potentially impact their 90-day mortality. The magnitude of the difference overall is quite small. So if you look at the actual percentage differences, you can see that it's actually the difference between a 3% mortality, 3.1% mortality, or 3.2% mortality. But also, it's a fairly high mortality rate in general. I mean, this is a high-risk patient population. To say that 3% of people were having this outcome is pretty significant. And then if you sort of think about how many patients are actually coming to surgery that are on dialysis, I mean, these are large numbers of people. So even if the actual overall increase is not that large, it's potentially affecting a significant number of people. And the actual odds ratio as far as how much that's increasing risk is that 25% increase in risk. It also increased in kind of a dose-dependent manner. So the more days meant higher mortality. So there's some plausibility there that it wasn't just a fluke number. And then the increased risk of that 3-day interval was attenuated by patients that actually got hemodialysis on the morning of surgery. So that risk was actually then reduced or went away as if you gave them dialysis. And if we look at actually the patients who have dialysis in general and their mortality rates, this was a paper that looked at the ratio of actual to expected deaths for dialysis patients. So were more people dying than you'd expect for that time frame based on the time after their dialysis. And interestingly, unexpected deaths increased in the first 12 hours after an HD session. And the thought was, well, you're having all these potassium fluxes, you have greater chance of ectopy and arrhythmias, you have an increased sympathetic tone right after dialysis because you're removing so much volume in such a short period of time. And then on the last day of a dialysis-free weekend, there's also an increased rate of sudden death. And again, this may be more related to the volume overload, hypertension, and potentially hyperkalemia. But there are variability. There is variability in the day of, timing of dialysis, even just with, patients that are in the community having sudden death. So what we can summarize is that there is likely little benefit to waiting longer than 90 days after a stroke before elective surgery. So in our patient in this example, we would probably proceed because it's been 4 months, but recognize that in general, recurrent stroke and mortality is increased over the baseline regardless of the time frame. So those numbers that I showed you on that first slide, those are pretty high rates of recurrent stroke regardless. But there's not a way to reduce that further by waiting longer. Immunosuppressants carry different perioperative risks based on the category. So be aware that many of your DMARDs, and those are sort of your methotrexate, sulfasalazine, many of them can be safely continued, and even probably the most conservative group, like the orthopedic surgeons, where they're really worried about outcomes after elective total joint replacements, their guidelines also say to continue. So it's not just us saying this. And biologicals should most often be held or surgery timed at the end of the dosing interval. And some of them have quite long dosing intervals, so it's even up to 7 or 8 weeks. But again, we can reference our SPOCI, the Society for Perioperative Assessment and Quality Improvement guidelines, to give us some guidance there. Perioperative mortality is increased with longer intervals between dialysis and surgery. And ideally, we should plan for the surgery on the day after dialysis. But if it's really impossible to do so, hemodialysis on the mornings of surgery is still better than not doing hemodialysis for 3 full days and then proceeding with surgery. Perfect. So we'll move on to our second presenter.
So I'm going to switch gears a little bit. I don't have one scenario, I have a few. So let's talk this morning about a 69-year-old with a history of hypertension, hyperlipidemia, obesity for ventral hernia repair. Patient comes to your clinic preoperatively and has an abdominal ultrasound where the liver appears to be consistent with cirrhosis. You have some moderately elevated transaminases, maybe like in the low 100s. The albumin is 4, you have a bilirubin of 1 and a platelet count of 126. What would you do with this patient? Would you stop, assess for signs of decompensation, or delay for evaluation? Okay, so there is some controversy. Some people would proceed. And I can say that probably 2 of the answers are correct. So if you did B or C, I wouldn't say necessarily either of them are wrong. So let's look a little bit, right? We have cirrhosis, and we know patients with decompensated cirrhosis do poorly perioperatively. But there are stages of cirrhosis, and this is taken from the British guideline for gastroenterology. You can tell that you're going from fibrosis all the way to decompensated cirrhosis where the damage is irreversible. Oh. What did I do? I went backwards, I'm sorry. So definitely it's something that you should look for signs of decompensation in somebody that you think may have cirrhosis. And what are we looking for? We're looking for jaundice, we're looking for ascites, fluid overload, we're looking for signs of upper GI bleeding, and we're looking for encephalopathy. Those are the signs of decompensation. But I wanted to popularize a little bit among you, probably a guideline that just appeared last month, published by the American College of Gastroenterology in perioperative care of patients with cirrhosis, because probably it's not on your radar to read necessarily GI literature, and they put out recent guidelines. So we know that portal hypertension per se is a predictor of postoperative complications. But how do we detect that? Generally, that is an invasive procedure that you have to do. And pulmonary portal hypertension is defined as more than 5 millimeters of mercury hepatic venous pressure gradient, but there's something called clinically significant portal hypertension. So a little bit more than 5, that's defined as 10, and clinically you can find that out if the patient has present varices, but not all patients will have an endoscopy done pre-operatively for you to be able to detect that, but there's also a non-invasive liver measurements that you can do. So you can send your patient, if indeed there's any signs clinically that the patient may have cirrhosis, for a fibroscan, which measures your liver stiffness. And in conjunction with the platelets and what you're getting from your liver stiffness, there's a higher or lower likelihood that the patient may have clinically significant portal hypertension. And these are the measurements and the platelet counts. I mean, you won't remember them, just keep in mind that they're there. So if you do decide that the patient has portal hypertension that's clinically significant, would you proceed with surgery or would you do something different? Obviously, I told you that if you have portal hypertension, you'll have probably not great postoperative outcomes. So what you would do, you would refer your patient to hepatology and probably start non-selective beta blocker such as carvedilol. Now keep in mind that carvedilol, in order to affect outcomes in the outpatient settings, it takes 2 years. The data from the Pradeshi trial that I'm mentioning here in the bottom shows decreased mortality and decreased risk of decompensation at 2 years. So that doesn't mean that, you know, just because it takes 2 years for something to work, you won't do anything preoperatively about this patient. And most likely it's going to be also surgery dependent. I was talking to you about something that's happening intra-abdominally, which is definitely much higher risk than, let's say, bunion surgery, right? I mean, for bunion, you'll probably just, unless the patient's fully decompensated and it's florid in your face that the patient has jaundice, ascites, then you would stop surgery. Probably if you did bunion surgery and you see a little cirrhotic liver and the patient looks good, you'll probably go. But I wanted to give you these nuances to keep in mind. However, if you send your patient to hepatology, maybe some of you are not familiar with a vocal pen, but it's something that's very ingrained in a hepatologist's way of doing things, of discussing risk of surgery based on the vocal pen score. So they're not using the CPT or the MELD anymore, they're using vocal pen, and this is, again, ascertained in the guidelines that it's the best scoring calculator to use for these patients. If you're not aware of it, you can just Google it and you'll find it. You can input all these data, the age, the albumin, the bilirubin, platelet count, and some other criteria here. And for our patient that I was telling you, if you look at it, you're going to get mortality at 30 days up to 180 days and the rate of decompensation. So it's a little bit different than what we get from RCRI or from, you know, the American College of Cardiology, less than 1% risk of MACE, more than 1% risk of MACE. And I asked my hepatology friend, so what am I going to do with this information? Because I'm like 13%. What am I going to do with 13%? Is it high? Is it low? And she couldn't really give me an answer. Basically, what she told me, she's like, we would tell the patient that if you're going for surgery at this point, you will have a 90-day risk of 13% of having decompensated cirrhosis. And that's what the discussion should be like preoperatively in somebody like that. So I'm going to talk about another patient with cirrhosis. Let's see what you think about this person, 39-year-old with compensated hep C cirrhosis that presents for distal pancreatectomy and splenectomy with a platelet count of 42,000. How would you address the thrombocytopenia preoperatively? So no action, platelet transfusion, romiplostim or avatrombopag. Both drugs in the bottom are thrombopoietin receptor agonists. Platelet transfusion. Well, I would dare to say that if you go back to the guideline that you just presented, that's probably not the correct answer. So this is a high bleeding risk surgery, right? I put splenectomy on purpose. I didn't put ventral hernia repair or bunion surgery. I put splenectomy. We know splenectomy could bleed. What happens with a platelet transfusion when you're transfusing somebody with cirrhosis? They basically all go into the spleen. So your platelet count will not go up. So let's talk about thrombopoietin receptor agonists. These are data from a meta-analysis that was published on 1,500 patients, and you can tell that it increases the platelet count by 35,000, and it decreases also the rate of platelet transfusions in patients with cirrhosis. So these drugs are FDA approved for patients with cirrhosis to raise the platelet count with no increase in mortality and also no increase in thrombotic events. But there is a little bit of a logistical issue with TPO-RAs as far as administration and as far as who's prescribing it. So it does need a pre-authorization, and it's not the gastroenterologist that's prescribed it, it's actually the hematologist that's prescribed it. So it's a little bit of a bump in the road. But if you think about the fact that the platelet transfusion is not only not the best thing to do for your patient, it's probably worth waiting for somebody that's not undergoing emergent surgery. So they're dosed differently. The two ones that are FDA approved for hep C cirrhosis are the ones I'm mentioning here, but you have to initiate them probably 2 weeks before surgery, and they're dosed for 5 to 7 days, after which you have to wait a little bit for the effect to peak, and you have to have surgery scheduled during the peak effect of the drug, which is 5 to 8 days after your last dose. Let's hope some of you are doing cardiac surgery. I put cardiac surgery on purpose to be more controversial here. So let's talk about SGLT2 inhibitors. I know it's one of the favorite class of drugs because I've talked about GLP-1s way too much. So a 75-year-old with coronary artery disease has reduced ejection fraction 40%, type 2 diabetes, A1C of 7.1%, CKD with a creatinine of 2.5 for cabbage. And he's taking empagliflozin 10 milligrams daily. The patient is showing up on the day of surgery and has not stopped their empagliflozin. They took the empagliflozin yesterday. Go or no go? Let's say this is not for acute coronary syndrome. This is for, sorry, should I redo the poll? So it's not emergent. Let's see, hands up, who would go? Okay, 5 brave people would go, very good. Okay, but still, no go was the more common answer here. Of course, the concern is the development of euglycemic ketoacidosis, right? In these drugs, we know that they increase the level of ketones. How do they do that? Through the kidneys, you're losing your glucose and your sodium, and you're absorbing ketone bodies. And on the other hand, through the pancreas, you're decreasing your insulin secretion, releasing fatty acids from your adipose tissue, which get transformed to ketone bodies in the liver. So the concern in cardiac surgery, if you look at the literature, it's probably the highest risk of euglycemic ketoacidosis among all surgery as far as surgical risk. It's described to be at least 15%, if not even as high as 70%. I think 70% has some issues. It's more ketosis rather than ketoacidosis, but it's at least 15% per the most recent data that we can find. So based on these concerns, the FDA published their advisory in 2020 and revised it in 2022 for these drugs to be stopped for elective surgery for 3 days for the shorter half-life drugs and 4 days for the longer half-life drug. However, is this the end of the story? We have some more recent data. This is a study that I'm showing you that was really hot off the press a few months ago, that was published in ANA. This was a cohort of patients that was done before any advisory of stopping anything. All these patients continue SGLT2 up to the day before surgery. All these patients had HFrEF with a less than 40% ejection fraction, and 40% of them had type 2 diabetes. If you look here, the risk of the perioperative myocardial injury was definitely decreased in the patients who all continued the SGLT2 as compared to the control group, which was not on SGLT2. And the post-op overall outcomes were driven by that. So there's less myocardial injury in the patients that have HFrEF undergoing cardiac surgery. And again, these patients continue SGLT2. Not only that, but you know, SGLT2s are not only approved for treatment for HFrEF or HFpEF, but they also are approved for kidney protection. And we know cardiac surgery is a big driver of acute kidney injury in these patients. So these are data from a retrospective study that was just published in September, 5,000 patients with type 2 diabetes for major surgery. The cohort included patients from 2013 to 2023. It was a Korean study, and in Korea, the hard stop came in 2021 as far as their guidelines changing to stopping the drugs, but it included patients from before. And the SGLT2s were compared to DPPIs, and they looked at AKI within 7 days of surgery. They could not tell who exactly stopped and who didn't stop. But obviously, there was a cohort of patients that didn't stop SGLT2s because it included patients from before the advisory. But if you see here, the majority of the benefit was actually in patients that underwent cardiac surgery who had pre-existing heart failure. So those are your highest risk patients. So unfortunately, you have high risk of EDKA, but you also have huge benefit as far as post-op myocardial infarction and protection for AKI. So probably the best thing would be for these particular patients that have pre-existing CKD and heart failure with reduced ejection fraction to continue with mitigation strategies such as insulin and glucose. I didn't put here another slide. We have a Japanese study on 700 patients where nobody developed EDKA, but everybody was on glucose because that's what they do in Japan. The maintenance fluids actually have glucose. So even the patients who didn't stop and continued SGLT2 and underwent cardiac surgery did not develop EDKA. And let's talk about the last scenario. This is somebody that has pulmonary embolism. So a 54-year-old with metastatic colon cancer scheduled for ileostomy reversal. So this is elective. I put it on purpose. It's not an emergent. It's not going for cancer. He's on apixaban for an incidentally found PE a month before. How would you manage your surgical planning here? Would you suggest an IVC filter placement, proceed with holding your DOAC, or postponing surgery for 2 months? Okay, no controversy here, or a little bit. But I think the majority picked the right answer, which is postponed for 2 months. So what we know is that a VTE event needs to be treated if it's provoked for at least 3 months. And the data show that probably for an unprovoked one, you should do 6 months of anticoagulation. There's a huge increase in recurrence of VTE if you stopped your anticoagulation prematurely. And assuming that for the majority of surgery, you would have to stop your DOAC, there's a 40% risk of recurrence at 1 month and 10% risk of recurrence at 2 months if you prematurely stop your anticoagulation. Now, I want to mention that none of the major society, ACCP, ACC, are actually coming forward saying you should postpone surgery. Who is it that's putting this statement out? It's actually the American College of Surgeons. The ones who want to go forward actually put the brakes and really stated that you should wait to do elective surgery within 3 months of a VTE event. So in summary, keep in mind that in patients with cirrhosis, if you have clinically significant portal hypertension, you're at high risk of perioperative complication, mostly decompensation. Use your vocal PEN score when you're trying to assess the risk and have a shared decision making together with your patient and your surgeon. The thrombopoietin receptor agonists are indicated in increasing the platelet count before surgery, but they have to be timed right. SGLT2s generally are stopped perioperatively. However, in this particular case that I gave you, the benefit is driving the balance a little bit more towards continuing, and elective surgery should not be performed within 3 months of an acute VTE event. And with this, I will pass the mic to my last co-presenter, Dr. Bobby Jean Schweitzer.
Thank you, Dr. Preya. Those were excellent lectures. I'm sorry that I have to go last, but I'll try to keep you guys awake and entertained. I think this podium was set up for people of Dr. Gerlach's height, not for Dr. Preya and me. I'm going to start with a case as well. This is a 64-year-old patient who was scheduled for an elective inguinal hernia repair, and he had a myocardial infarction about 45 days ago. It was an acute event. He went to the cath lab. They did an emergency PCI with a drug-eluting stent, but he had post-procedure persistent angina and concern for persistent ischemia, so decided that he needed to go for a CABG. So he had that CABG just 35 days ago. He's been on aspirin, clopidogrel, rosuvastatin, losartan, and carvedilol since that time. What do you think about the timing of this inguinal hernia? 45 days after an MI, 45 days after a drug-eluting stent, and 35 days after a CABG. Go or no go? "100% of you guys." Well, I think we're done with the lecture. We'll just everybody leave for now. I'll give you your time back. So I do want to point this out because actually, with all disclosure, I was part of the writing committee for the 2024 AHA-CC guidelines, and somehow we failed to put anything in there specifically about the timing of non-cardiac surgery after an acute myocardial infarction. There's information in there about after CABG and after PCI with stenting or PCI without stenting, but not actually just a myocardial infarction. So I kind of put them all together so I could talk about it over one case. But there was a recommendation back in the 2014 guideline that showed, that the recommendation at that point was 60 days. When these guidelines were first developed, I think the first one was published in 1996, I think they said 6 months. It came down at some point. I think it was the 2004 guideline was as close as 7 days after myocardial infarction. They thought it was safe to go ahead. And then it started growing again in length. You can see here from this data, this was from a study that was done in 2011, showing that, the risk doesn't really level off to where we think is a baseline risk, which is typically about 3%. People who have coronary artery disease have about a 3% risk of event for non-cardiac surgery. That event is probably a bit higher just with having a myocardial infarction itself. It's kind of hard to separate out MI with heart failure versus just MI. But these studies are, showing patients with major surgeries and patients all comers, both those who had not severe heart failure with that, but they could have had some heart failure or no heart failure. We do know that heart failure on top of a myocardial infarction further increases one's risk. But we're becoming more and more apparent that simply having a myocardial infarction is a strong predictor of worse outcomes than just having baseline stable coronary disease. And this is one of those slides that show that. This is a 30-day mortality in patients who underwent surgery within either a 0 to 30 day. Across the x-axis is the timing of when they had non-cardiac surgery in relationship to their myocardial infarction. And you can see that even people who had had a myocardial infarction a year ago, there was still a statistically significant higher risk of 30-day mortality in those patients when they had non-cardiac surgery. So the risk probably never goes away. This was actually also I found very fascinating. So this is 1-year mortality in patients who would have undergone non-cardiac surgery within a period of time. So I'm going to walk you through this a little bit. So again, if they underwent surgery within 30 days of myocardial infarction, they had a 14%, that's that on the left, of mortality within 30 days. If they underwent non-cardiac surgery within 30 days of myocardial infarction, they had almost a 50% mortality on this right side if you measure them out to 1 year. So I always think, would patients really want to have an elective procedure if they thought they were going to have a 50% chance of being dead in a year, whether it was directly related from that surgery or something else? But also to put this in perspective, we know that patients who do have perioperative complications within the first 30 days after surgery, from a variety of reasons, cardiac, pulmonary, surgical site infections, have significantly higher mortality that's tracked out to a full year. So they're sort of not out of the woods yet until they're at least past a year post-op. So increasingly, I think we're being held to those kinds of numbers that, it used to be okay if the patient went home from the surgical encounter. Then it was 7-day mortality and morbidity. Then it was 30-day. Now, many people are saying we should be really looking at a 1-year outcome. Because for most patients, if you tell them that they're going to have significantly worse, outcomes or be dead within a year, they'll be like, well, I don't know that I necessarily want to undergo any kind of surgery, or it has to be really pretty minimal surgery that gives me a pretty major benefit in that short period of time, because I only have a year left to enjoy. So this is, another interesting study that also just came out just recently this year that looked at STEMIs, or technically MINS, which is myocardial injury after non-cardiac surgery. Because we're seeing a lot of this in our institution where patients come in with, some sort of acute illness and they have a troponin leak. And now they've got this elevated troponin, and now they want to have some non-cardiac surgery. And often that is just ignored. In fact, the patients often are not even telling us that they're aware that they had a troponin leak. And we know from other data that there's about a 10% mortality without other surgery. Just if you have myocardial injury after non-cardiac surgery, within 30 days after that, if you do not undergo further surgery, there's about a 10% mortality associated with that. So Dr. Glantz looked at this group, and he looked at two groups. First, those who did not have revascularization. So unlike the patient that I presented to you earlier, even though his was a ST segment elevation, but you can see their deaths, they didn't ever have fewer deaths if they didn't undergo revascularization. This is, I think, similar to what I showed you previously, that data for a myocardial infarction. So it appears that an NSTEMI is just as bad as a STEMI, essentially. And now if you look at the MACE, or the major adverse cardiovascular events, the complications, not just death, those also they follow these patients out to 2 years, they never reduced back to a normal rate. So again, it's a strong marker, even in NSTEMI, of patients who are going to be at risk in the future with or without further non-cardiac surgery. They did look at a group also, though, with revascularization. This was both CABG as well as PCI. And you can see there that, up to about 60 days afterwards, there was still a high risk of death. So they essentially recommended that at least a 60-day wait. I think that supports the previous data I showed you of waiting for at least 60 days. But they actually didn't show that this is kind of topsy-turvy. They showed that initially the MACE rate was actually lower in the initial period and got worse over time. There's some other data to support that too, especially with PCI, that there may be this magic period, but more on that. So this was another study, and again, what the real point I want to point out from this study is the difference between high-risk non-cardiac surgery and low-risk non-cardiac surgery. Because most of the studies I've just showed you and most of the information has been about patients who have had myocardial infarctions undergoing major surgeries. And it's like, well, is that still applied to the patients having more minor surgeries? If you look on the left, for the elective surgeries, it did make a difference. High-risk surgery did carry significantly higher risk than low-risk surgery. But if you looked on the right side with the non-elective or the more urgent or emergency surgeries, it didn't matter whether you were undergoing low-risk surgery. It carried as high of a risk as those patients who were having major surgeries. So again, this is just a different study. This was also just published, but their data showed that it was best to wait probably 100 days or 3 months after a CABG. And I think that the ACC 2024 guidelines say exactly the same thing. So what about stents? Well, pay attention, because this is also new from the 2024 ACC guideline. If you have a drug-eluting stent, now you need to determine whether that was placed for an acute coronary syndrome, like the situation I showed you in that case, or is it placed for a non-acute coronary syndrome for stable disease. So if it was an acute coronary syndrome, they now say delay for 12 months. It's no longer 6 months. It's 12 months, and they give it a level 1 recommendation. Anytime you see a green in the 2024 or any of the ACCHA guidelines, green means they're all in, they give it the highest recommendation. They feel the benefits or the positive outcomes of that recommendation far outweigh any risk of not following that recommendation. And then they grade it yellow, orange, and red. And by the time they get to red, it means don't do something. But if the stents were placed for chronic stable disease, they're sticking with this 6 month. But they noticed they gave it only a yellow. That's the second highest level. They felt that there was still a little bit of controversy about the timing of that. We have known for some time that patients in non-perioperative settings who undergo stenting in an emergency setting, like most emergency surgeries, most emergency procedures, carry higher risk. It's probably because they don't have enough time to really size the stents well. They may not have the perfect size of stent. They may not be able to fully sort of, place that stent accurately because the patient may be very unstable in the cath lab while they're having acute coronary syndrome. They're at risk for acute kidney injury, and they don't want to give them too much dye. So it's kind of a hurry up and put a Band-Aid on that problem. So this is, I think, the first time that this is carried over into the perioperative setting, is to change the recommendation to extend that time. They do recommend, again, it's an orange, so it's slightly less strong, and just because there was less data to support this, because most people are waiting well beyond the 3-month period. But they say that you should almost certainly always do your best to wait for 3 months. And there's very few surgeries that really need to be done in less than 3 months. That includes even cancer procedures. There's quite a bit of data from a variety of cancers, even relatively aggressive cancers like lung cancers, that if you take time to wait, stabilize patients, correct some comorbidities, they're more likely to be alive at a year later with not any more progressive cancer than those who hurry up and get through their cancer operation. They do recommend that there's no evidence to support going ahead in less than 1 month. There is a relatively new drug-eluting stent on the market, and it's designed to be placed in patients who have a high bleeding risk, who may not tolerate dual antiplatelet therapy for a long period. So it's being studied. There are no data whatsoever yet of this stent in the perioperative period. And by definition, patients who have high bleeding risk may have a low thrombotic risk, and vice versa. High bleeding risk may have low bleeding risk may have a high thrombotic risk, and so these patients may be particularly at risk in the perioperative period. Remember, surgery is a particularly high thrombotic episode. Dr. Oprea's evidence, supported that as well, that the surgeon's concerned about that. More patients typically die of thrombosis than die of bleeding. And if one clots off a drug-eluting stent in the perioperative period, some estimates are that carries a 50% mortality. So again, 12 months if the stent was placed for non-cardiac. So we're back to that same patient again. Here we are, and I want you to vote again. This one is, should we continue, or should the patient continue the ARB when the patient is ready to have this surgery? So continue, whole day of surgery, or hold for 48 hours. Pardon me? Oh, okay. Well, I'm sorry. Apparently I didn't update this. I apologize. So all you have is continue and hold. So most people are voting, but again, I love it when it's, pretty sort of even, because it only takes a few people to sway in one direction or the other. So we know that for some time, I'm not going to try to tell you that continuing ACEs or ARBs will not mitigate your hypotension. If you continue ACEs or ARBs, you will see more hypotension intraoperatively. However, one probably has to stop the ACE or ARB for up to 48 hours or more to mitigate that hypotension. And if you do that, those patients are more likely to present on the day of surgery with hypertension and more likely to have hypertension in the post-op period. So there's some evidence that if you don't restart our ACE or ARB in the post-op period in a very timely manner, typically within 24 to 48 hours, there's a much higher risk of adverse outcomes. And patients who don't come in on drugs are much more likely to not have those drugs restarted. So yes, hypotension occurs. But the real question is it that we will or will not see hypotension, but does that result in harm? So this was a study that, was a few years ago, this was 7 years ago, that showed Again, hypotension occurs, and it favors withholding if you simply want to mitigate hypotension. However, when they looked at major adverse cardiovascular events associated with those patients, there was absolutely no difference in those, whether they held them or they did not hold them. When they looked at mortality, there was absolutely no difference in whether they held them or they didn't hold them. Well, fast forward, we're still studying this 7 years later, or this was, I guess, 6 years later. This was published last year. This was the STOP study, and this looked at whether they held or continued. And you can see that they did it for either 24 or 48 hours. No, they held them for 48 hours, and then they monitored troponins, which is the best way to determine, MINS or myocardial injury. If you're waiting for patients to have symptoms, many patients do not have symptoms. If you're waiting for them to have ECG changes, many of them do not. And they showed absolutely no difference here, you can see, in whether the patients continued or did not continue. In fact, there was a trend, and a couple of these were significant, that there was benefit. Down at the bottom, the green ones had a lower risk of poor outcomes in patients who continued their ACEs or ARBs. So it appears that even though their patients are hypotensive, that the ACE or ARBs protect them. And studies show that they protect them not only for cardiac events, but there's some evidence it protects against stroke and as well as AKI, though there was one study, a sub-study of the VISION trial, that was the only study to ever show harm from continuation or ACEs or ARBs, and that did show an increase in AKI. From that one study. This was another study that just got published last year. Again, continuation or not continuation. This was the STOP or not randomized controlled trial, and you can see that graph tracks completely together. And this looked at all-cause mortality as well as major postoperative complications. They followed the patients out for 28 days, and there was absolutely no difference if whether they stopped or continued. So the ACC 2024 guideline did say that they gave a fairly strong recommendation of 2A at the bottom there, that if you were taking a RAS for heart failure, it's quite protective, much like I think the SGLT2s and those patients, having cardiac surgery if they had heart failure, that you should continue it. And they say it's also reasonable to continue all antihypertensive treatments, but they did kind of sit on the fence. I think the reason that they sat on the fence with the RAS was because when this guideline was developed, those last two studies I showed you had not yet been published. This did come out right after those studies, but it was already in press, and so they did not have the results. In fact, they addressed that in the 2024 ACCHA guidelines, that depending on what those two studies showed, it may sway them in a different direction. So I do believe the very next rendition of this will strongly recommend that we continue ACEs and ARBs for all patients, regardless of the indication. So in summary, there's a high risk of MACE and death with non-cardiac surgery soon after STEMI or NSTEMI. I put delay as long as possible. I know that's quite vague, and for most people who know me, I like to be very definitive about things. But I think the jury is still out about, if you're not getting revascularized, how long you need to wait, because there seems to be no low-risk period for the rest of your life. But I do think that 3 months after CABG is pretty clear. I think the data supports that. 6 months after a PCI for stable disease, 12 months after PCI for acute coronary syndromes, and continue those ACEs and ARBs. Thank you.
So we're available for questions if you want to.
Dr. Schweitzer, I loved your talk, especially talking about holding versus continuing ARBs. I have a theory of what's going on with ARBs with the new studies versus the old studies, and there's a study that just dropped in anesthesiology this morning. Since about 2017's ASA, when Dr. Sester was talking about MACE and MINS and intraoperative hypotension, a lot of us have gotten a lot stronger about using drugs like phenylephrine, or especially now norepinephrine, to prevent these drops in blood pressure. And if you know that ACEs and ARBs cause intraoperative hypotension and you're already prophylactically treating them with norepi or phenylephrine, you're going to see less of that. So I think more modern studies are being conducted in that clinical milieu and maybe showing the safety of ARBs in the perioperative period. And the study that just came out this morning showed a dramatic decrease in cardiac events if you just start people on norepinephrine if they're over 50 and ASA2 or greater. I encourage everybody to look at that one.
Yeah, thank you for that. That was excellent. I did not see that. That's really hot off the press, literally this morning.
Is this the one in JAMA?
No, he said anesthesiology. Yes. Yes, it's that I agree with you. I think we've gotten better, right? I think we've also gotten better at taking care of people with ischemic heart disease, and that's why I think patients often do better. But now we know, the heart failure patients, we need to learn how to take care of them better. But even when there was hypotension, so even when they looked at same blood pressures, the ACEs and ARBs tend to have protection. And I think we know that from non-perioperative settings, right? ACEs and ARBs protect people. So it's like a lot of things in life, when you start an anticoagulant for a thrombotic episode, you lower the risk of clotting, but you also raise the risk of bleeding. You just always hope that you never raise the risks of something more than you lower the risks of something.
And as a cardiac anesthesiologist, I'll also say, I think the difference there between, it's not the same to say I'm going to start a phenyl drip versus a norepi drip versus, an epi drip versus vaso. I mean, again, I think there's a pure alpha agent that's actually potentially worsening cardiac output and worsening, cardiac disease and causing increased strain. There's a big difference between that and something like norepinephrine that has some beta activity as well. So I'll be interested to review the paper.
Yeah, I would say caution, try to avoid hypotension by mitigating your induction agents, by decreasing your SIVO, by using, EEG monitoring, for example, in frail elderly patients or somebody. And don't just use, heart rate and blood pressure, because you can squeeze them to death, right? We call it leave them dead, as a sort of pun for Levophed. You need some cardiac output. You need some stroke volume. You need some perfusion. And it's not all perfusion is not just your blood pressure and how tight your blood vessels are.
Perfect. Thank you. Another question.
Yeah, I feel like these diabetes drugs are like back when metformin was canceled due to this concern about metabolic acidosis, and then they did a lot of studies that said, yeah, glucose control matters way more than this theoretical concern. I've never canceled the case for SGLT2s or GLP-1s. You can easily diagnose and treat euglycemic ketoacidosis. A patient with diabetic gastroparesis has like a fourfold higher risk of residual contents than someone on these GLP-1s. We don't cancel those cases. We just, risk stratify and proceed. And I suspect eventually we'll be continuing these drugs, primarily for glucose control, if not the other benefits. Any thoughts on that?
Regarding which ones?
Both of them,
about
either
GLP
one,
for another
GLP-1s or
hour.
SGLTs. Do you think long-term, what's your prediction on where we're going with these drugs?
Where we're going with these drugs. I think GLP, there's strong data to say continue, right? And there's much stronger data to suggest that actually diet is more important than stopping the drug for a whole half-life, right?
Yeah.
I mean, if you want to stop that drug, which obviously nobody's going to say anymore to do that, you would have to have at least 4 weeks for the long-acting drugs for the effect on gastric emptying to completely dissipate and allow that patient to just follow the standard ASA fasting guidelines. Until then, I think strong data support a 24-hour clear liquid diet before with continuing, right?
Cite the papers. Tell them where to find
yeah,
out.
if you have not read our SPACI consensus guideline yet, I'm sorry I don't have it on the slide. I took it out actually just to make shorter slides. It's published in BJA in July. It's called the SPACI Multidisciplinary Consensus Statement on Perioperative Management of Patients on GLP-1. Now, regarding the SGLT2, if we're done with the GLPs, again, fasting is actually the most important driving risk factor for euglycemic ketoacidosis. Dr. Bobby Jean Schweitzer and I have recently reviewed the literature up to literally last week on what's been published. And yes, there is a risk, but the risk is mostly driven by dieting, by being MPO for a long time or by being on a very low-calorie diet. Obviously, the other point is diabetes drives you up. Patients that are now on SGLT2s just for heart failure or CKD have a practically very close to zero risk. It's a very, very, clear non-risk for those patients. So if you're just for heart failure or just CKD with no diabetes, your risk is practically inexistent, with the exception of these two categories of prolonged MPO or bariatric diets. So, to conclude that, probably the majority of patients that do not have to fast for a long time, definitely those coming for outpatient procedure, not going for bariatric surgery, can continue, whether with or without they have diabetes. Patients with cardiac surgery that I mentioned now, yes, there's a high risk of EDKA, but there's also huge benefit for AKI, right? And the rate of EDKA is 15%, the rate of AKI is 25%, right? And that drives the cost even more, and mortality and morbidity cardiac surgery-wise. In between, let's say, again, outpatient surgery, low-risk surgery, it's all fine, especially if the patient's not fasting. Major surgeries, yes, major surgery will drive your glucagon up, you'll drive your insulin down. In a patient with diabetes, there will be some risk, but also that patient will be admitted to the hospital. As you said, they're easily monitored for EDKA and started on insulin and glucose should you have to do that. And that should be easily treating the thing. And even in non-cardiac surgery, there is benefit. I mean, I didn't have time to go through that, but there is some benefit, especially in the patients that are at risk for AKI.
Okay. Sounds like you think generally continuous medications is the way to go.
With those exceptions.
With those exceptions, of course, yeah.
Yes, and if you can't discontinue them. And I think that's an even more important point to make. And I think this was part of the problem with some of the ACEs and ARBs, right? Like, you can't always discontinue them, right? It's emergency surgery. It's more urgent surgery. So then we need to learn how to manage those patients, right? And then if we learn how to manage those patients in that setting, then we can apply that to those patients that we decide we electively want to let them continue, or the ones who make a mistake or, continue them. So in general, I think that, these, most of the time when you have medications that are beneficial for patients in everyday life, most studies that have been done on them have shown that they have benefits in the perioperative period. They may have unique risks, but so you have to weigh that. And even with anticoagulants, right? We sometimes give low molecular weight heparin on the morning of surgery to somebody who's at a high risk of VTE because we don't want them to, and that may increase your bleeding a little bit. So it's always this push-pull of look at the, consequences of when I do something and when I don't do something, when I continue something, when I discontinue something. Now, if they're worthless medications like supplements and that sort of thing, then, just stop them.
I think this is also relevant when there's something like where the FDA says, SGLT2s stop 3 days before surgery, and yet we're saying at this panel, no, continue it. I think that's where this conflict comes in, and especially for people that work in a pre-op clinic, how do you make a policy that's going to satisfy the majority of people in your department when there are some things to be cautious of with these medications? We do have to understand how to manage these patients appropriately, and especially when people have concerns because published recommendations say stop them. How do you support the recommendation to specifically actually continue them in certain situations? So I think that's why there's a lot of subtlety here, and way you may fall one way or the other. You may be someone that has said, well, I've never had problems, I'm just going to continue. Or you may be someone that says, well, the FDA is telling me to stop, and why are you telling me to continue? I should probably stop. That's kind of where the subtlety here comes in.
Since you're doing these guidelines, have you addressed the new insulin? There's a new insulin that lasts 24 to 48 hours. And patients have held it, and their sugars still drop, sometimes precipitously while they're fasting. I'm blanking on the name of it, but it's a very long-acting insulin, and they can hold it, and their sugars will still go down. I've seen a couple episodes of high glycemia. I'm blanking on the name, but I looked up this drug, like, what? The 24-hour
Patients actually
plus.
get hypoglycemic because most of the, long-acting insulins are designed to be, effective as basal insulins, right? Like,
That is true, but
typically,
also people are over basal. Type 2
well, sure,
diabetics
and they try to do it with
use
one,
their-
right?
It's this nutritional versus baseline. So when you assume that you dose insulin because someone's eating and their basal insulin rate is because they're eating during the day, and then you keep their basal the whole time and then they stop eating, you actually haven't compensated for their nutritional component. Is that fair to say?
Dr. Prey and I were both,
Dr. Priya is
practiced
the expert on.
in the hospital, and we know that the classic rule of thumb was when you admit a diabetic to the hospital, you decrease their insulin regimens by about 2/3 or something, right, half, because now you're controlling the caloric intakes. right?
So you're talking about Tresiba or Trugeo, right? That are the 72 hours insulins. They're not that new. I mean, the one that's 7 days has not been approved yet that I know about. That's going to be a new thing. Are you talking about the U500? Because
No, it's,
U500 is very different.
It's Degludec.
Degludec, yeah.
Degludec, yeah.
Tresiba, yeah.
It lasts like
Yeah, it's
up to
72
40
hours. It's 72 hours. You should treat it like a Lantus. Technically, it does not have a peak, and technically, even if you're dropping a little bit, that is the problem. The problem is you're talking about patients with type 2 diabetes who use a lot of their basal to actually cover meals, and now they're not eating. You know, but the drop should be not that surreptitious. I mean, if you have any issues ever with insulin, it's usually the MPH. The MPH will have a peak and will drop you. I've always seen that intra-op, and the patients will drop. But with the peakless ones, the long-acting ones, not as much.
Well, it's not rapid. It's just, I think it's longer than the others, but
Right.
24 hours to hold, it still goes down. Meaning you held it for 24 hours and it still drops during the surgery.
Yeah, but that may just be a natural course, right? Because
I'm
now
a little
you've got-
surprised because, I mean, everything would tell you that glucose goes up during surgery, right? We're
Right,
always
right.
afraid of hypoglycemia, but
if it's a
actually
minor
hyper.
surgery. I just wanted to mention a little bit about the FDA. So I think that, thank you, Dr. Garrett, for bringing that up, you know, because we are standing up here saying to do something different than the FDA does. And, you know, like just some people in the audience probably are like, I don't cancel these cases either. I think one has to be somewhat cautious when you go against, you know, recommendations by the FDA, by the American College of Cardiology, American Heart Association, et cetera. But, you know, we know that those guidelines can never quite keep up with the emerging data and evidence. And so, you know, SPACI puts out a lot of guidelines. We hope in the very near, you know, future there'll be an SGLT2 guideline by SPACI. We do have that guideline that we referred you to in the British Journal of Anesthesia. And so, you know, that's a major society that looks at more recent data than the FDA. The FDA, you know, recommendation was back in 2020, right? And a lot of it was, you know, dated information back then. And so I think that just be sure that you always, when you do something, you have a really good, strong reason for doing it, and it's backed by some evidence that applies to that patient, because guidelines can also be quite broad. So, for example, with the, you know, SGLT2s, I think, you know, Dr. Prey alluded to, you know, it's probably very nuanced. It's the type of surgery the patient's having, it's their fasting state, and that's just the risk of the DKA. And then you have to look and say, well, what's the benefits, right? And there's a group of people, like those with heart failure or those who are at risk for acute kidney injury, where the benefits may outweigh even a relatively high risk of DKA. And we also know that we're learning that we can mitigate that by giving insulin and glucose, just like we can mitigate the hypotension of the ACEs and ARBs by using certain drugs, but not all of them are equal. So just, you know, I applaud you guys for all being here, trying to stay up to date, learning, and, you know, realizing that it's very individualized, personalized care at the end of the day that you deliver to a patient.
That brings us to the end of our session. We're around afterwards if you have any questions, and please feel free to email any of us if you'd like further information. Thank you for coming.